Inferior mediastinum is subdivided into anterior, middle, and posterior compartments. The anterior compartment is the smallest part of the mediastinum. It's just a thin cleft-like space between the body of the sternum and the transversus thoracic muscles anteriorly and the pericardium posteriorly. This space is filled with loose connective tissue, referred by some authors to as sternopericardial ligament, a little bit of fat, a few lymph nodes, and the branches of the internal thoracic vessels. As we previously discussed, the inferior part of the thymus may descend to the anterior mediastinum in infants and children. In some rare cases, this lymphoid organ may extend to the level of the fourth costal cartilage. The middle compartment is the broadest part of the inferior mediastinum, and it contains the pericardium, the heart and ascending aorta, the inferior and superior vena cava, I mean the intrapericardiac parts of these vessels, the tracheal bifurcation and main bronchi, the pulmonary trunk, the right and left pulmonary vasculature, phrenic nerves, the deep part of the cardiac plexus, and the trachea, bronchial lymph nodes. We have discussed the heart and great vessels and pericardium in our previous lessons, so we can move on to the posterior mediastinum now. The posterior mediastinum is the space behind the heart. It contains the thoracic aorta, thoracic duct and lymphatic trunks, posterior mediastinal lymph nodes, azygous and hemiazygous veins, what else? The esophagus and esophageal nerve plexus. And we will discuss all these organs one by one. Some authors also include the thoracic sympathetic trunks and thoracic splanchnic nerves. However, these structures lie lateral to the vertebral bodies and are not within the posterior compartment. The thoracic aorta begins at the level T4-T5 and descends through the posterior mediastinum, reaching the aortic hiatus of the diaphragm. The thoracic duct and azygous vein ascend on its right side and accompanied through the hiatus. The thoracic aorta gives off several paired branches to the thoracic wall and viscera. In descending order, these include the bronchial arteries. Those supply the bronchial tree and do not participate in the pulmonary circulation, remember. Mediastinal arteries, which supply the lymph nodes and other tissues of the posterior mediastinum. 2 to 5 esophageal arteries, pericardial arteries, superior phrenic arteries to the superior surface of the diaphragm, and these anastomose with the muscular phrenic and pericardiac phrenic branches of the internal thoracic artery, and of course the paired posterior intercostal arteries, the branches that supply the walls of the thorax. The venous blood from the posterior wall of the thorax is collected by the azygous on the right side and hemiazygous on the left side veins. Both ascend parallel to the vertebral column in the posterior mediastinum and collect the blood from the posterior intercostal veins. At T9 level, the hemiazygous vein crosses the vertebral column and enters the main azygous vein. The azygous vein arches over the root of the right lung and enters the superior vena cava. Accessory hemiazygous vein, collecting the blood from the upper 5 to 8 intercostal veins, may also be present, but not always. The azygous vein also receives the mediastinal and esophageal, prevertebral, and bronchial veins. The next organ for us to review is the esophagus. On its large extent, it rests in the posterior mediastinum, and it has a soft wall and is usually flattened anteroposteriorly. Initially, it inclines to the left, but is pushed back to the median plane by the arch of the aorta. Inferior to the arch, the esophagus again inclines to the left. As it approaches and passes to the esophageal hiatus in the diaphragm at the level of T10 vertebra. The soft wall of the esophagus is compressed by three structures: by the arch of the aorta, by the left main bronchus, and by the diaphragm. These areas may be observed as narrowings of the lumen in the oblique chest radiographs that are taken as barium is swallowed. No constrictions are visible in the empty esophagus, so don't try to find them on the cadavers. However, as it expands during filling, the structures noted above compress its wall. These impressions are clinically important because of the slower passage of substances at these sites. The impressions indicate where the swallowed foreign objects are most likely to stuck and where a stricture may develop, for example, after an accidental drinking of a caustic liquid such as lye. The thoracic duct is located in the posterior mediastinum and has close relations with the aorta and esophagus. As you remember, it is the largest lymphatic channel in the body, which collects lymph from the lower part of the body and from the left part of the upper body. The thoracic duct originates from the cistern of Chyle and in the abdomen just under the diaphragm and ascends through the aortic hiatus in the diaphragm through the posterior mediastinum, among with the thoracic aorta on its left side, the azygous vein on its right, the esophagus anteriorly, and the vertebral bodies posteriorly. At the level of T4, T5, or T6 vertebra, the thoracic duct crosses to the left, posterior to the esophagus, and ascends towards the left venous angle. Posterior mediastinal lymph nodes scattered all through the esophagus and thoracic aorta. These receive lymph from the esophagus, the posterior aspect of the pericardium and diaphragm, and from the posterior intercostal spaces. Lymph from the nodes drains to the right or left venous angles via the right lymphatic duct or the thoracic duct. The radio-opaque shadow of the mediastinum is produced by the heart and large vessels, such as the arch of the aorta and superior and inferior vena cava. The shape of the shadow may differ reflecting the type of body constitution and may be transverse in obese persons, pregnant women and infants, oblique in majority of people, or vertical in tall people with narrow chests. But you always will be able to differentiate the apex of the heart, the right and left counters of the heart, and the aortic cup. If any abnormal shadows are spotted, the lateral views should be taken and evaluated as well. Now, when you know what exactly is located in front, behind, and above the heart, it will be much easier for you to read the abnormal radiographs. Now you know that the abnormal shadows in the superior mediastinum may be produced by the thymus, lymphatic ducts, or the arch of the aorta. In the posterior mediastinum, the lymph nodes around the esophagus itself, and the spinal cord could be herniated or dilated, producing the shadow. In the middle mediastinum, the pericardial bag, heart, and dilation of the ascending aorta could add to the mediastinal silhouette.